Everyone. So I call this meeting to order. So welcome everyone to meeting number 19 of the House of Commons Standing Committee on Health. The committee is meeting today to study the emergency situation facing Canadians in light of the second wave of the COVID-19 pandemic. So I would like to welcome the witnesses. From the National Advisory Committee on Immunization, we have Dr. Caroline Quactin, Chair and Professor, Université de Montréal. From the Public Health Agency of Canada, we have Stephen Bent, Director General, Kimberly Elmsley, Senior Vice President, Ursabel Ephraim, Director General, Center for Communicable Disease and Infection Control, Cindy Evans, Vice President, Emergency Management, Dr. Guillaume Poliquin, Acting Scientific Director General, Dr. Roman Chomsky, Senior Vice President, COVID Vaccine and Therapeutic Acquisitions. I would just summarize that the above witnesses are asked to present on the following: A, current outbreaks, occurrences, and modeling for COVID-19 variant spread in Canada as it relates to projected vaccination rollout timelines. B, capacity to surveil the emergency prevalence and spread of variants. C, current federal government assumptions regarding vaccine effectiveness on variants in the context of the federal government's vaccine portfolio. And D, Canada's procurement of variant-related booster shots. According to the motion that requested this panel, I will ask Dr. Quactin to speak for up to 7 minutes, followed by the Public Health Agency of Canada for up to 15 minutes. So Dr. Quactin, please go ahead, 7 minutes.
Thank you very much. So, je tiens d'abord à remercier le président.
Thank you. I would like to begin by thanking the Chair and the members of the Standing Committee on Health for this invitation to appear. I am pediatrician, microbiologist, infectious diseases specialist, and clinician scientist at the Saint-Justine University Hospital Centre and a full professor at the University of Montreal's Department of Microbiology, infectious diseases and immunology. My expertise as a clinician and researcher is in infection prevention, both in hospitals and the community, and it also extends to vaccination. I am a Tier 1 Canada Research Chair in Infection Prevention and Control. However, today I am appearing as the Chair of the National Advisory Committee on Immunization, so I will limit my comments to its mandate.
The Committee on Immunization, or NACI, is an external advisory committee to the Public Health Agency of Canada and has existed since 1964. The NACI work and committee attendance for the 15 voting members and the chair is done on a voluntary basis and carefully reviewed for any conflicts of interest. NACI makes recommendations to the Public Health Agency of Canada on issues relating to immunization, for the vast majority on vaccines that have been authorized by Health Canada. In only one instance was NACI asked to make recommendations on a not yet authorized vaccine to support emergency preparedness, the Ebola vaccine. NACI bases its recommendations on various elements, including the burden of illness, vaccine characteristics such as safety, immunogenicity, and efficacy, ethics, equity, feasibility, and acceptability, as well as economics. To ensure that NACI has the proper expertise, it expanded its voting membership in recent years to include a social scientist, 2 health economists, and epidemiologists, and consults regularly with the Public Health Ethics Consultative Group. NACI uses a systematic approach to review the medical literature and vaccine science, which may take longer to perform compared to a narrative review, but ensures reproducibility and quality so that provinces and territories are confident about the knowledge synthesis product they can then use for their local recommendations. Compte tenu du besoin croissant de recommandations.
Given the growing need for recommendations on COVID-19 vaccination, NACI has steadily increased the frequency of its meetings and is now meeting once a week. The Secretariat supporting NACI is part of the Public Health Agency of Canada, and it has worked diligently to provide NACI with the data needed to make decisions, such as literature reviews, ethical analyses, and tables of management options outlining various approaches based on provincial epidemiology and values unique to each province. Since the beginning of the pandemic, NACI has issued a number of statements, including a research priorities statement to help inform manufacturers' randomized phase 3 trials so they address important questions, allowing NACI to make recommendations for vaccine use for various populations, including vulnerable populations, 4 recommendations on priority groups to be vaccinated in various circumstances, and 2 recommendations on the use of COVID-19 vaccines, one for each vaccine authorized by Health Canada.
Variants asked by HESA, and in keeping with the NACI mandate, I cannot comment on the vaccine rollout. However, NACI has variants of concern, or VOC, on its radar, having added many research questions over time in our recommendations on use of COVID-19 vaccines. The latest version remains to be published. These research questions feed both the Canadian Immunization Research Network's work plan and the newly formed Vaccine Surveillance Reference Group with a Safety and Effectiveness Working Group to identify knowledge gaps and leverage existing cohorts or surveillance infrastructure to answer these questions. The following questions relate to VOCs. What is the role of humoral versus cellular immunity in preventing immune escape of viral variants? How will viral variants impact the efficacy, effectiveness, immunogenicity, and safety of a vaccine with respect to death, severe illness, symptomatic disease, asymptomatic disease, infectivity, and transmission? What is the effect of using booster vaccines containing heterologous antigens? And what is the optimal timing for booster vaccination? At this point in time, NACI has requested presentations of vaccine effectiveness data from the UK, where the B117 variant is the most predominant SARS-CoV-2, in a country where both AstraZeneca and Pfizer-BioNTech are used with an extended interval of 12 weeks. Data were presented to NACI confidentially on February 8, 2021, after 4 weeks of follow-up of individuals vaccinated with the Pfizer vaccine. Public Health England will be presenting again an update on their results next week at the regular NACI meeting. Based on data from the literature, NACI considers that the available mRNA vaccines remain effective against the VOC that emerged in the UK. Studies show that following 1 dose of the Pfizer-BioNTech, participants' sera exhibited a broad range of neutralizing titers against the wild-type virus that were only modestly reduced against the B117 variant. The introduction of the E484K mutation in a B117 background led to a more substantial loss of neutralizing activity. Neutralizing antibodies were lower in those 80 years and over in a separate study. However, antibody response, as key as it may be, is not the only type of immunity that is of importance. Cellular immunity also plays an important role in protecting the individual. As there are no known correlates of protection, and as we are likely going to see the emergence of other new variants over time, it is paramount that Canada and the world invest in surveillance and tracking of variants, identifying those of concern, analyze new variant sensitivity to neutralization by vaccinees' sera, study vaccine protection of animals against challenge with new strains, and sequence viruses causing breakthrough infections in vaccinees. This will allow for real-time vaccine effectiveness surveillance alongside VOC's identification and surveillance. The spread of the VOC that emerged in South Africa, the B1351, may be more detrimental. Data from recent randomized clinical trials where VOC circulating showed that although these vaccines, the vector-based and Novavax, remained efficacious against the B117 variant, they had decreased efficacy against the South African variant. The phase 3 studies that were conducted for the mRNA vaccines were done at a time when VOCs were not yet prevalent. However, we are aware that some of the leading vaccine manufacturers are already working on new versions of their COVID-19 vaccines adjusted to target the B1351 or other variants. NACI is monitoring the data and will issue a statement if a booster or new dose is needed, including consideration of any new vaccine candidates that are authorized by Health Canada. NACI is also monitoring the use of heterologous vaccine schedules. Preliminary results from an animal study show that a combination of mRNA and AstraZeneca elicited a stronger cell-mediated immunity. The UK started a study where AstraZeneca and Pfizer will be administered as a mixed schedule. Recruitment started at the beginning of February, and NACI will be monitoring the results from this study. For over 50 years, NACI has been providing evidence-informed expert advice to the Government of Canada on vaccines. Viral variants or different strains of diseases are not a new phenomenon, and we have a long history of adapting vaccine programs to the changing evidence in areas such as influenza, where new vaccines are needed every year, or pneumococcal disease, where different strains have waxed and waned, requiring dynamic vaccine technologies and program redesign over the years. NACI is poised to adjust this new vaccine program if needed as the evidence evolves. I thank you for your attention and will be happy to answer questions as they relate to NACI's mandate.
Thank you, Doctor. We'll go now to the Public Health Agency of Canada. 15 minutes, please. I should note that when you're 1 minute away, I'll raise a yellow flag, and when your time is up, I'll raise a red flag, and I'll ask you to try to keep an eye on that and wrap up as soon as you can. So thank you. Please go ahead, Public Health Agency. 15 minutes, please.
Thank you, Mr. Chair. Honorable members, thank you for this opportunity to speak to you about the COVID-19 variants and the actions that the Public Health Agency of Canada is taking to protect Canadians during this pandemic. I'd like to start with a bit of background information on the variants. All viruses mutate over time. It's only natural that the virus that causes COVID-19 will also mutate. By mutate, I mean change the genetic material in the virus. While all viruses mutate, not all mutations are of concern. A variant of concern is a mutation that has the potential to impact on the characteristics of the virus. A variant is of concern when it affects the disease spread, disease severity, the tests used to detect the virus, or affects vaccines and treatments. We are working with international partners, including the World Health Organization, to build our knowledge base and better understand the COVID-19 variants and their potential impacts. In recent months, several COVID-19 variants of concern have emerged internationally. As of yesterday, we're aware of 3 variants of concern in Canada, those first identified in the United Kingdom, South Africa, and Brazil. The situation with variants of concern in Canada continues to evolve rapidly. As of February 16th, there have been a total of 637 cases across provinces, which are associated with variants of concern reported publicly. To date, there have not been any variants of concern identified in any of the territories. The majority of cases in the provinces have been the B117 variant first identified in the United Kingdom. The majority of these variants are linked to travel. However, there is evidence of community spread, as there have been cases where there is no direct or indirect link to international travel or to travelers. 5 provinces, British Columbia, Alberta, Ontario, Quebec, and Nova Scotia, have confirmed the B1351 variant first identified in South Africa. So far, the P1 variant, first identified in Brazil, has only been confirmed in Ontario. Between mid-January and mid-February 2021, there have been 21 outbreaks of COVID-19 in Canada, which are associated with a variant of concern. These have occurred in a variety of settings, including long-term care, workplaces, healthcare, childcare, schools, residential apartments, and social gatherings. Ontario has reported the majority of these outbreaks with a total of 13. Quebec has reported 4, Alberta 2, and 1 each in Manitoba and Newfoundland and Labrador. The variants of concern continue to spread in Canada, and it's likely they will become more widespread over time. We are continuing to track emerging variants both in Canada and internationally. As our understanding of these variants increases, we will update our guidance on case and contact management and community-based measures. Evidence from other countries shows that COVID-19 activity can be brought under control, even when variants of concern are widespread. Strict public health measures, along with strong border controls and strict adherence to personal protective practices, can slow the spread and impact of variants of concern. Slowing the spread will buy us the time we need to get Canadians vaccinated. Vaccine manufacturers are investigating the impacts of the known variants of concern on their vaccines. There are reports that certain types of vaccines may be less effective against the variants of concern first identified in South Africa and in Brazil. However, given the limited data on the new variants of concern, more research is needed to confirm these early findings. As new variants are identified, it's more important than ever that we continue to follow recommended public health measures. Since the beginning of the pandemic, public education and communications have played a critical role in the Government of Canada's response to COVID-19. We work closely with the provinces and territories, public health partners, multicultural and Indigenous organizations, and other stakeholders to make sure that information is accessible to all Canadians, and that up-to-date information and public health guidance is available on a wide variety of channels. I would now like to turn to my colleague, Dr. Guillaume Paulequin. He will talk to you about sequencing, surveillance, and vaccines. Thank you. Merci.
Merci. Comme ma collègue a indiqué, je vais...
Thank you. As my colleague stated, I will be talking to you about sequencing, surveillance, and vaccines. Canada has a federal, provincial, and territorial approach to surveillance. This involves frontline healthcare settings and laboratories across the country. Our approach has effectively equipped us to detect respiratory illnesses, including COVID-19. We have worked with provinces and territories and other stakeholders to accelerate diagnostic testing capacity in order to detect cases of COVID-19 and its variants more quickly. The National Microbiology Laboratory monitors Canadian cases of COVID-19 with the provinces and territories through ongoing analysis of genomic databases in Canada. Since the beginning of the COVID-19 pandemic in Canada, the Public Health Agency of Canada, Health Canada, and the Canadian Institutes of Health Research have been working with Genome Canada and provincial and territorial partners on sequencing. Sequencing is used to determine the DNA of the virus in order to help identify different variants. This data is an essential tool to track how the virus is both changing and spreading. It can help us quickly detect known and potentially emerging variants of concern. In April 2020, the Government of Canada committed $40 million to support the creation of the Canadian COVID Genomics Network. This investment will enable sequencing efforts across Canada that will help us understand the genetic variations of the virus as it evolves. These early investments have helped put us in a leadership position so that we can rapidly detect and respond to the variants of concern that have emerged and are spreading around the world. The National Microbiology Laboratory and the Canadian COVID Genomics Network have worked with federal, provincial, and academic scientists, epidemiologists, and infectious disease clinicians to establish priorities for sequencing. These target the identification of existing variants of concern through the regular sampling of positive cases. These include, but are not limited to, suspected cases of reinfection and vaccine failure. Sequencing is also targeting high-risk scenarios that may signal the presence of potential new variants of concern. Canada is on par with top surveillance programs in other countries. We sequence more than 5% of the positive caseload in the country. We are also deploying additional capacity to scale up further. Our objectives are to increase our sequencing to 10% and to decrease turnaround times. The National Microbiology Laboratory is working with provincial partners to ramp up screening positive cases for known variants of concern. Screening capacity is increasing in many provinces. At the same time, the Public Health Agency of Canada is tracking daily counts of variants of concern across Canada. The agency has worked with provincial and territorial partners to reach agreements to track cases that have been identified as having a variant of concern. This agreement includes sharing epidemiological information so that we can do a comparative analysis of variants of concern cases versus cases where the variants are not of concern. This analysis will allow us to detect characteristics that might enhance our understanding of how public health measures need to be adapted to a variant of concern. To further support our efforts, the government is investing $53 million in an integrated variants of concern strategy. This investment will increase our capacity to find and track variants of concern in Canada. It will also help rapidly scale up surveillance, sequencing, and research efforts to inform the public health response. Through this partnership, we are leveraging existing laboratories and expertise to respond more quickly. So, this national strategy brings together public health and genomic sequencing along with epidemiology, immunology, virology, and mathematical modeling. Through this partnership, we are leveraging existing laboratories and expertise to drive public health investigations and take public health action rapidly. To implement this strategy, the Public Health Agency of Canada's National Microbiology Laboratory is providing $20 million. CanCoGen is providing $8 million to increase genomic sequencing and real-time data sharing capacity. And the Canadian Institutes of Health Research is providing up to $25 million to scale up Canadian research to increase our understanding of emerging variants. This will help provide decision makers with rapid guidance for drug therapy, vaccine effectiveness, and other public health strategies. The Public Health Agency of Canada is responsible for procuring vaccines on behalf of the Government of Canada. Based on the expert recommendations of the task force, clinical information and authorizations by Health Canada, the agency has worked with Public Services and Procurement Canada and other federal departments to develop an evidence-informed vaccine strategy. This strategy focuses on securing a diverse portfolio of leading COVID-19 vaccine candidates. The portfolio of candidates serves to provide every person in Canada with access to safe and effective vaccines as soon as they are available. Canada was an early investor in COVID-19 vaccine technology and has advanced purchase agreements with 7 leading vaccine developers. To date, the Pfizer and Moderna vaccines have been authorized by Health Canada. 3 others, AstraZeneca, Janssen, and Novavax, have submissions with Health Canada for regulatory authorization. There are also others that are progressing well through clinical trials. Canada's approach to its vaccine strategy took into account the many uncertainties that are inherent in the global vaccine supply chains. It also considered the evolving nature of the virus and its impact on vaccines. The global emergence of variants of concern has reinforced the value of having a diversified portfolio of vaccines. Canada is monitoring emerging evidence of the impact that variants of concern have on the effectiveness of the vaccines in our portfolio. Consistent with our focus on supporting evidence-based decision-making, the Public Health Agency of Canada continues to work closely with its partners to monitor the evidence on all fronts. And we continue to adjust our efforts when necessary. The agency is working with the provinces and territories, international partners, the scientific community, and health systems to collect evidence on the variants. This will help us determine how they are impacting Canada's immunization efforts as well as those of other countries. At the same time, the agency is working with its federal partners to engage vaccine developers on how their vaccines will protect against variants, including the potential need for booster doses to protect against variants. In our current portfolio, we have secured enough vaccines for everyone in Canada to have access to an authorized vaccine by September. We are confident in our vaccine portfolio, but we recognize that it is not static. As we learn more, we will adjust the strategy to ensure it continues to be effective. We are actively exploring all options that can help us strengthen our vaccine portfolio and support our immediate and long-term needs, including making sure that all Canadians have access to boosters if they are necessary. To say this last year has been a difficult one is an understatement, but we have come a long way. We have seen the positive effect of the public health measures we have been practicing. They are effective, and they help prevent the spread of COVID-19, including variants of concern. Now is not the time to give up. We've come too far for that. Until we are all vaccinated, it is more important than ever to keep the practices that have gotten us this far, that we keep up the practices that have gotten us this far. Thank you.
Thank you. With that, before we get going, I wish to emphasize that everyone has the right to participate fully in these proceedings in the official language of their choice. If at any time there is any interruption or problem with the translation services, I urge affected members to advise the chair or the clerk without delay. We will do our best to correct the situation. Also, I wish to remind all members that they should mute their microphone when they're not speaking. And with my personal apologies to the translator, I seem to be the worst offender here, so I shall try to do better. With that, we will start our rounds of questions. If we play our cards right, I expect we can do probably 3 rounds of questions. I also would like to note that it is my understanding, Dr. Kwok-Tan, that you have to leave at 4 o'clock Eastern, if that is correct.
That is correct. I have another meeting for my day
Great.
job, sorry.
Thank you. So that being the case, I would recommend to the members that any questions they might have for Dr. Kwok-Tan, that they move them or make sure they're done in the first couple of rounds. That being said, we will start with the Conservatives. I don't have who is the first speaker.
It's me.
Very well. Go ahead, Ms. Rempel-Garner.
Thank you, Chair.
6 minutes.
To Mr. Sumsky, I'm concerned about our ability to get booster doses of vaccines that are targeted towards the variants. Do the contracts that we've currently signed with vaccine manufacturers, specifically Pfizer and Moderna, include booster doses, or do we have to negotiate separate contracts for those?
Mr. Chair, the current contracts that are in place do not reference the need for boosters, and those would be new conversations that we would enter into with the suppliers.
Have you started to enter into negotiations with suppliers or any supplier for booster doses?
We are engaged directly with the suppliers and keeping current with their tracking of vaccine performance and plans for boosters or updates to their vaccines. They currently do not have boosters that are available for distribution, or it's going to be a while yet before that's in play. But the discussions with them are on a rolling basis.
Does the vaccine acquisition branch have any concern about any of the contracts that have currently been signed with regard to efficacy against the UK or South African variant?
Mr. Chair, the vaccines that we have, the 2 that are authorized are the Moderna and the Pfizer, which have very, very strong efficacy in the Wuhan strain, the original strain. So if they have an alteration in their efficacy as a result of variants and they lose some of their efficacy by 10%, 20%, or even a bit more, they still will be very useful tools and vaccines that you would want to deploy widely in your population.
Is there a threshold of efficacy that you would no longer employ an original vaccine against?
The vaccine, I'd have to refer to Mr. Chair, I would have to refer to experts to understand what that threshold is, and that would be a question of deployment. So if the vaccines reach a state where the experts are advising that they shouldn't be deployed, then clearly they will follow that. The people that make the decisions to deploy the vaccine will make those alterations.
Thank you, Chair. To Dr. Ephraim, today your department announced new pandemic projections. The modeling shows that while the original COVID-19 epidemic is slowing, the trajectory changes considerably when new variants are factored in. The modeling that was released today, the forward-looking projections, how many vaccinated persons did that assume? I can ask again, how many?
Dr. Ephraim, I think you're muted, or Ms. Seprin.
Can you hear me now?
Yes.
Okay. Thank you, Mr. Chair, for the question. I would suggest that this question be answered by Ms. Emsley, who will be better positioned to answer this question.
To Ms. Emsley, and I've lost Chair about 30 seconds now. How many vaccinated persons did your modeling assume?
We'll have to get back to you with the exact numbers on that. I don't have them in my notes at this point in time, but it's easy for us to bring that back to you very quickly.
Do you think it's problematic that these numbers were released to the Canadian public without the ability to answer that question?
I just don't have it in front of me at this moment in time. I'm not sure if Dr. Poliquin
Can you please table that with committee this week?
Yeah, definitely.
Thank you. Can you also tell us how the amount of deployment of rapid testing, how that affected your modeling?
I will refer that to Dr. Polycan on the testing question, please.
Mr. Chair, the modeling that was presented today is looking at projections for the number of cases that could be expected based on a number of different conditions.
Could you please table with committee the conditions that you had made assumptions on with regard to your modeling today?
Yes.
By next week? By next week?
Yes.
Thank you. If Canada at the federal level had a vigorous rollout plan for the deployment of rapid tests, would that change the modeling that you presented today?
So as we will return to you with the number of inputs that goes into these models to be remitted.
Do you think it's concerning that you can't answer that question at this hearing today?
Mr. Chair, the models that are presented are a number of complex modeling exercises that involve a number of different inputs. It is difficult to
What
tease
inputs
apart.
are those?
They include reproductive numbers, and they include a number of trends, as well as the interplay of the rollout of vaccination and expected disease transmission patterns. Therefore, it is difficult to tease apart individual assumptions at the moment.
Why is Canada's modeling for the spread of the variant so different from other countries? Why do we show such a greater trend as opposed to models that have been recently released in, let's say, the EU or the US?
Mr. Chair, the models that are presented involve a number of different scenarios, including working in, for variants of concern, a range of potential increased transmissibility. The model that was presented today involved a 50% increase in transmissibility over the wild-type strain.
Did it assume the deployment of rapid tests?
The interplay of testing with the number of cases is a different question.
So that wasn't included in today's modeling?
We will return to you with the full set of assumptions modeled today.
Did the inclusion of unapproved vaccine candidates factor into your modeling today?
Of unapproved vaccines?
Yes, like AstraZeneca or J&J. Were you just assuming we were proceeding with the existing schedules of Pfizer and Moderna?
So the interplay of the vaccines involve a number of different assumptions, and we will return to you with those.
By next week?
Thank you, Ms. Rempel-Garner.
Yes.
Thank you.
We go now to Dr. Pawlowski. Dr. Pawlowski, please go ahead, 6 minutes.
Hello, we're here to talk about the variants, and certainly the one I think that's spreading most in Canada is the British variant, which my understanding is may be more infectious, but the vaccines still work on it. So I think it seems to me the biggest question concerning vaccination right now is how far we can go between the first shot and the second booster shot. I know Moderna has done studies that show after one dose, it has a 92% efficacy. I think you will probably be familiar with the data coming out of Quebec that showed that 80% of elderly people were covered after 3 weeks. And I think healthcare workers, 80% were covered after 2 weeks. So I know in Quebec, the strategy has been to prolong the period between the first and second shot. And certainly if you can go 3 months, that'll double our ability to get people vaccinated quickly. So will public health, but let me throw in there, I know Israel had, I think, some concerns with one shot being effective in the elderly. So I know there may be some competing data out there, but I wonder if the Public Health Agency of Canada or NACI will be making recommendations about the interval between first and second dose. And at the moment, what are those recommendations? Thank you.
So I guess I can take this one if you don't mind, Mr. Chair. You have seen that NACI had recommended, given the data on hand at the time of publication, that we asked that the 2 doses be given preferably within a 42-day window period. That was based on the fact that in the two phase 3 trials, the Pfizer and the Moderna trial, participants got their second dose between 21 or 28 days up to 42 days, and that was an average estimate. We have now seen the data from both the UK and Quebec, and we are aware that Quebec is using a 3-month interval. I think that what we are going to make a new recommendation, so we're currently working on that. But the main idea is to try and balance the advantage of spreading out an 80% vaccine effectiveness to more people, allowing then a public health, a population health impact that is usually greater. But I think that the question that remains unanswered is the duration of that 80% protection. So we have asked the UK to come back next week to give us an extended view on their now 6 weeks of follow-up. And Quebec will also come back to present an updated vaccine effectiveness data. So as we move forward and we see that we have some leeway, we are going to be able to allow for longer interval. I think that we do not want to have a falling vaccine effectiveness to the point where we could be at risk of seeing variants become a problem. And so that balance is not an easy one to tackle without data. Thank you.
A second question on vaccines to cover the variants. My understanding is that Moderna and Johnson & Johnson are already working on tweaking their vaccines. It seems fairly easy with both of those technologies. There's minor changes on the spike protein. You change the vaccine a bit. Are you going to require that the vaccine producers with these new tweaks go through the usual process of phase 1, phase 2, phase 3 trials, or can that be expedited given the fact that so far it seems like the vaccines as they are safe?
I mean, from a NACI standpoint, we will follow what Health Canada allows. We hope that it will not require a phase 1 and phase 2. We think that the discussion is already ongoing, but I don't see anybody from Health Canada here. And so I don't know if Kim wants to answer that one.
I would only say that that is a question for the regulatory authority at Health Canada, and one, of course, that we can take back and ensure you receive an answer to.
How much time do I have left?
A minute and a half.
Okay, let me ask a bit about prioritization. I want to get a shout out in support of the police. I know that NACI's made recommendations about priorities. I know, having spoken to the police in Thunder Bay, that they're in a bit of a difficult position. They are certainly at high risk. They're the ones that really can't keep their hands off people. They're at risk of having their masks removed. I think I'm not sure, but I think there have been cases within the police force here, and a lot of people having to be off work. We have a limited number of police already. This is a big problem. I know that the ambulance drivers are being immunized. I know at least some of Emerge, where I used to work, are being immunized, but the police aren't. What is the plan in terms of prioritizing them? Thank you.
So, Mr. Chair, the difficulty here is that prioritization then is a provincial and territorial aspect and decision. So NACI has put frontline essential workers, including policemen, in their stage 2 priority. So they are there at the same level as the ambulance workers and the others. So as long as the province you're in will put them on their list, then that will happen. But they have been prioritized. Thank you.
Thank you, Doctor. Nous allons maintenant à Monsieur Thériault.
Now, Mr. Thériault, go ahead.
Merci, Monsieur le Président.
You have 6 minutes. Thank you, Mr. Chair. Pardon me. I will take advantage of the fact that Dr. Quash is here in order to ask her questions. I would like to thank you for being with us again. You've been with us before, and hopefully, well, today's speech was very technical, so I will try to say it in simpler terms. People have concerns. Marcus Piloski talked about it earlier. the matter of one dose and the space of time, the time between both doses, the need for a booster. What we heard by the SPQ yesterday was quite interesting. It was good news. They said that the vaccine is 85% effective, and according to data available, the second dose would only increase effectiveness by about 10%, and without knowing the time frame, it could be effective for a longer period of time, but that just one dose could bring us to revaccinating. That wasn't excluded. So if we want to vaccinate as many people as possible for collective immunity, I would like to know what you think about this news, and is the second dose necessary? Is it perhaps only the prerogative of a company that wants to have its own brand and to ensure that everything's working, because that can change everything? Answer. Thank you for your question. I did see the data, and it is quite interesting. Having 85% efficacy on a very senior population, an ill population in long-term care is quite interesting. The need for a second dose now is that this second dose allows antibodies to become more mature, and so they're more solid, they're stronger. So we're improving the fit between the key and the lock, and so there's a more long-term protection. There's a risk in using only one dose because we don't have data on a program with only one dose. Perhaps eventually we'll have some data on that, on Johnson & Johnson's program, for example, but the efficacy is not as good for the African variant, the South African variant, and so they're studying the possibility of adding a second dose to see if that changes things. So the 10% additional efficacy, that's not necessarily what brings us to offering that second dose. It's mostly to have a more long-term protection, because we don't want to constantly have to revaccinate. We want the population to be protected against viruses that are going around. There was a study that was done in Quebec, published by the INSPQ. There were no variants of concern at that time. So it's only with the wild virus that we see that efficacy at 85%. When we'll see that the efficacy will decrease, well then that will be the time for offering the second dose. But currently Quebec will have an interval of 3 months between both doses, which allows them to vaccinate more people. Thank you. So that's if we have enough vaccines to vaccinate everyone. Do you know when herd immunity could be reached? Not necessarily in percentages, but in time. How long would it take? Do you have any scenarios that could say, well, it will happen in October or September? And also, what will be the measures for that herd immunity? We'll have to vaccinate everyone, of course, but once that's done, when will we need to offer boosters or revaccinate to continue to live with the vaccine? Answer. That's a good question, and my crystal ball is the same as yours. So it should happen in the fall, depending on vaccine rollout. 85% of our population should be vaccinated by then, but after that, we'll have to look at the time, like how long this protection lasts. Currently, we don't know for how long we will be protected with these vaccines. Studies examined 4 weeks and 3 weeks, or 3 months after the dose. So we'll have to continue doing surveillance to see for how long people are protected. This doesn't mean that we'll need consistent boosters. It depends on the variants. With our crystal balls that aren't really that effective or we might need a vaccine every year like the flu because there may be new variants. All right, I think I'm out of time. I'll try to come back to it later. Thank you.
We go now to Mr. Davies. Mr. Davies, please go ahead, 6 minutes.
Thank you, Dr. Quashtan. Has the emergence of highly transmissible variants of concern increased the level of vaccine coverage required to reach population immunity in Canada?
It does, because that herd immunity is based on the reproductive number, which was approximately 3 to 4 with the original virus and is 50% more, so 4 to 6 with those new variants. And therefore, you would need more closely to 85% of your population either immunized or protected through natural disease to be able to reach herd immunity.
Thank you. And that jibes with research coming out of the University of East Anglia, which found that initially 69% of the population would need to be vaccinated with the Pfizer vaccine or 93% with the AstraZeneca to bring the R number below 1. But when they took into account the B117 variant, they found that vaccinating the entire population with the AstraZeneca vaccine would only reduce the R value to 1.325. And meanwhile, the Pfizer vaccine would require 82% of the population to be vaccinated to control the spread of the new variant. To the Public Health Agency of Canada, have you conducted similar modeling for Canada?
So NACI is not doing such modeling at this point in time. We're looking currently more at the deployment of vaccines and what category of people should be vaccinated to achieve the largest public health gains. But we can submit that question absolutely to the PHAC modelers.
Thank you. I'd appreciate that. Do you expect that the UK variant, the South Africa variant, or the Brazil variant will become the dominant strain of the SARS-CoV-2 virus in Canada? And if so, when would you anticipate that would occur?
We sure hope not, but it's possible that it will come to life. I think that at this point in time, we have the sense that the UK variant is predominant in most of our provinces, not predominant, but is the variant that is the most prominent. We're trying through various public health measures to limit the spread of that variant, and maybe we'll be better than other countries because at least we know that it's there. But otherwise, because it is just more transmissible, it eventually will take over. We haven't seen much of the South African variant yet, at least not in Quebec. And so I think maybe Dr. Poliquin can answer more about that in terms of what is spreading, but it is a concern, absolutely.
Thank you. Well, in terms of the volume, we know that cases of the B117 variant have now been found in all 10 provinces. Mm-hmm. As of just 2 days ago, Canadian health units had identified 673 cases of the B117, B1351 and P1 variants across Canada. But experts are claiming that the real total is likely in the thousands, since testing for the variants differs across Canada, and of course not everyone will get tested. In your view, how close are we to having a real accurate understanding of the prevalence of these variants in Canada?
So I can only speak, from the NACI perspective, that has nothing to do with it. I can only speak from the Quebec perspective, where every single positive case is being checked for variants. And for the rest of Canada, I will refer to Guillaume for this.
Public Health Agency, can you answer that question? Or how accurate are we in understanding the prevalence of the variants?
So through the existing infrastructure, as of December, Canada was able to sequence about 5% of positives, and efforts are underway to reach about 10% of all positives in Canada. But that is a separate initiative to the rollout of screening assays to be able to rapidly look for variants of concern with a recognized genetic sequence. Efforts are underway through the Canadian Public Health Laboratory Network with support from the National Microbiology Lab to be able to screen all positives for.
Can you give us some context, Dr. Poliquin, that, 5 to 10% doesn't sound like much to me, but can you tell me in layperson's terms, how accurate are we in identifying the prevalence of variants?
So so there's two different thrusts to answer the question. One is the sequencing approach, and then one is the screening for variants, which uses different technology, and efforts are on the way to be able to screen all positives for the presence of a known variants with a known genetic sequence. When it comes to our overall sequencing capacity, we are on par with the leader countries in the space, including the United Kingdom, and are ahead of many other jurisdictions, including European countries.
2 days ago, on February 17th, the Public Health Agency of Canada confirmed it is monitoring reports of 2 variants of the SARS-CoV-2 virus, first thought to have originated in the UK and California, combining to make one heavily mutated hybrid. Could you outline the potential risks posed by such a recombinant virus?
So we are still, Mr. Chair, we are still monitoring that particular virus and strain and or variant, and learning more about its biology. It is not clear at this time whether this represents a true recombination event or further variants of an existing variant of concern, and we are closely monitoring the science to understand its potential impact.
Thank you. Mr. Chair, you're on mute, I think.
All right, thank you. So that ends round round one. We start round two with Mr. Barlow, I believe. Mr. Barlow, please go ahead, 5 minutes.
Thank you very much, Mr. Chair. I'm going to start with Dr. Quash Tan, and I apologize if I've mispronounced your name. In your presentation, you said the vaccines that we currently have approved are effective against the variants that we are aware of. However, on the NACI website, it says that there's no evidence that 2 doses of the approved vaccines have any effectiveness on the variants. Can you clarify that? Are the vaccines that we have approved currently effective against the vaccines? Yes or no?
So thank you for the question. What I've said is that the Pfizer and the Moderna vaccines, based on the studies that have been emerging after the statement, seem to be efficacious against the B.1.1.7. We don't have much data against the South African strain yet, variant yet. So against the UK variant, it seems to be fine. Against the South African variant, it still remains to be looked at.
Well, thank you for answering that, but that is different than the statement, and even reading the language in the statement, that's not what's said there. So I would encourage you to clarify that, and I'm glad you did on that question. Dr. Poliquin, to you, you stated during your presentation that you are now putting together a team of representatives from PHAC, virologists, epidemiologists, to look at a strategy to address the variants. I would think every expert would have known that the COVID-19 virus was going to mutate, and dealing with virus was going to be a problem, which is one of the reasons we're here. I'm a little shocked that we're a year into this and this is only happening now. Why is this team only being put together now to deal with variants when this is something I think should have been addressed much earlier?
Mr. Chair, thank you for the question. On the issue of getting ready for variants, Canada began its work to be ready for the detection and the characterization of variants in April of 2020 through the investment $40 million into the Cancogen Initiative. And through that work, we were able to study the early rise of variants of concern, including the emergence in the summer of the D614G variant, and provide characterization. what we are doing now is we are building on that foundation of success and further expanding our ability to sequence, to study, and to understand the spread of these variants through a combined robust surveillance program, including laboratory and epidemiology resources, and matched to a strong research arm that is able to swiftly work on a common research agenda to deliver information in as close to real time as possible to decision makers to inform further policy.
Thank you very much. And maybe to Dr. Polcan again, I was really concerned with some of the questions that my colleague was asking at the beginning, that none of these assumptions, the impact of rapid tests or new vaccines have had on this modeling that was done. Do you think it's irresponsible to release these models to the Canadian public without including those assumptions as part of the process, at least to MPs and the media? Do you not think this is irresponsible?
Mr. Chair, the models that are presented represent an ongoing and a refinement of our understanding of SARS-CoV-2 as the science continues to evolve. And as we learn more about a number of parameters, including transmission, reproduction number, vaccine efficacy, these models are updated and are presented. The assumptions are available and are made available to reseachers and to those that are interested, recognizing...
Sorry, Mr. Polkan, I only have a certain amount of time, and I appreciate that, Doctor, but Canadians are stressed. Businesses are closing, people are losing their jobs, and to have this information available to researchers, I think is irresponsible. This information should be available to every Canadian, and it should have been released with the modeling as background to where you're getting this information to the media and MPs here at this meeting, which you knew was going to be happening. Maybe to Dr. Quash, if you can answer this for me, please, or maybe Dr. Polkan, either one. Another major concern with Canadians, I know all of us are getting, is the mandatory quarantine at hotels when returning home. Is there any data that backs up the fact that quarantining in these hotels rather than at home is reducing the spread of the variant in any way?
I'll defer that to someone else because this is really out of NACI's mandate, sorry.
Well, that's okay, thank you. If Dr. Polkan maybe can answer that.
So on the so what we are continuing to do with respect to understanding the spread of variants is to continue to update our suite of public health.
So as of right now, you don't have any data that proves that the hotel quarantining in hotel reduces the spread of the virus.
Thank you, Mr. Barler. I'll let the witness answer, and then we'll carry on. Go ahead.
So at this time, we are continuing to update and monitor the impact of a suite of public health measures, including our border policy on the impact on the spread of variants and the introduction of variants of concern into Canada.
So you don't.
Thank you.
Thanks.
Thank you. We'll go now to Mr. Fisher. Mr. Fishers, please go ahead. 5 minutes.
Thank you very much, Mr. Chair. And as usual, thank you to all of the witnesses that are here today. And sorry, we're a little bit late. I guess my first question would be to PHAC. We're seeing vaccine deliveries ramp up very, very quickly here, quadrupling this week, and they're going to continue to rise substantially in the weeks to come. We know that the provinces and the territories have the delivery of healthcare, and they're responsible for getting the vaccines in the arms of Canadians. So I'm wondering, and I'm quite fascinated by just how complex this procedure must be. I'm interested if you could speak maybe to, the coordinating of our vaccine rollout with the provinces and territories, and just exactly what something like that looks like. As we ramp up, we're going to have, mass vaccination sites set up. Is that something that we play a role in, or your organization plays a role in at PHAC?
It's Kim Elmsley. Perhaps I will start off with the answer to that question. Thank you very much, Mr. Chair. So from the perspective of undertaking in terms of an immunization campaign this large and complex, I know that everybody in this room knows that this is unprecedented for us. What isn't unprecedented is the fact that we work really hard with provinces and territories and with public health officials across the country every day on preparedness and on execution. And so when it comes to this operation, of course, we have set up a national operations center that is running the logistics for distribution and is on top of vaccine deliveries 24/7. We have a committee of federal, provincial, and territorial officials, and those people are on the ground program immunization deliverers that are talking twice a week, if not more, about the things that they're seeing on the ground so that we can, at the federal level, support immunization program delivery. How do we do that? We do that by, for instance, ensuring that those programs have the types of syringes that they need to immunize Canadians. So when Pfizer went to a 6-dose vial from a 5-dose vial, we provided at the federal level the syringes that provinces and territories require to be able to get that 6th dose. We're also working with them every step of the way to look at issues of effectiveness and safety. So that's another important part of the rollout of an immunization campaign. It's not just getting the needle into people's arms, it's also doing surveillance after they've been vaccinated to see what the effect of vaccination is. That involves us using, for instance, vaccine registries, which are in provinces and territories and which we have provided additional support to so that we're getting good data and provinces and territories themselves are able to monitor what's going on in their jurisdictions. And so from all of those various pieces of, I'll call them infrastructure and machinery, both things that have been in place for a very long time. As Dr. Quash stated, every year we roll out 12 to 15 million influenza shots across the country. Provinces and territories deliver those in clinics, in doctors' offices, in pharmacies. So we're obviously very well prepared. For this kind of venture, which is more complex, we've beefed up everything so that we are able to be much more consistent in our execution, and we've practiced. So we've had proof of concept demonstrations with our colleagues at round tables, doing tabletop exercises, doing the kinds of things that one would do in terms of challenging each other on the what ifs. How are we going to handle it? What if this happens? How are we going to handle it? And so all of these things are part of the preparedness that we undertake with all jurisdictions on a regular basis. Thank you.
What about, and moving over to the NACI folks, we've got the Team Canada approach here in Canada. Is that something that your group plays a part in as well, is working out logistics and how we're going to ramp up that? I know that the chair is going to tell me that I'm just about out of time, but do you have a role? Do your guidelines speak to that as well?
Not at all. We are not part of the rollout. It's the Canadian Immunization Committee with the provinces and territories.
Okay, so there's no NACI component to how to when you have to ramp up when numbers of vaccines quadruple or increase massively over the next few weeks. Okay, no. All right. Thank you, Mr. Chair.
Thank you, Mr. Fisher. We go now to Ms. Rempel-Garner. 5 minutes, please.
Thank you, Chair. Is there anyone on the meeting today that provided advice to the federal government stating that implementing the quarantine hotel requirement would be more efficacious in preventing the spread of variants as opposed to implementing a border testing model such as what's in effect at the Calgary airport right now? Anyone? Is there any branch of PHAC that provided that advice? Nobody?
We will go back with that for sure. None of us on the call today have been directly implicated in that. And so I think it best for us to ensure we go back to our quarantine group and ensure that you get that information.
So was there, you guys are all the heads of the main departments in PHAC. What data was used to determine that quarantine hotels were a better option for stopping the spread of variants than the Calgary Border Pilot Program, which employs rapid on arrival testing? Anyone? Any data? Can any of you provide us?
We'll come back to you with those data.
When?
By next week.
Okay. So similarly, why would you, in a meeting this morning, say that continued lockdowns are necessary when we have rapid testing, therapeutics, and vaccines available to us to stop the spread of variant? What data was used to make that pronouncement this morning at the press conference with Dr. Tam and Dr. New?
So I can take that question, Mr. Chair. It is important to remember that a full suite of measures are required for the control of the pandemic, and the addition of variants further reinforces the need for a broad-based
Dr.
approach.
Falkman. Why is it, if we need a full suite of measures, that therapeutics, rapid testing, and vaccines weren't mentioned in the press conference this morning, only lockdowns?
So if we look to international comparators in terms of how the outbreak responds in a number of different contexts, we see that vaccines, public health measures, and testing are all inherently necessary to the control of the outbreak, and that with the introduction of the uncertainty posed by variants of concern, it is important for us to continue to maintain those.
How many people need to be vaccinated in Canada to stop the spread of the UK and South African variants per the modeling that was released this morning? Anybody? Did anyone come prepared for that question? To a meeting about variant spread and vaccine efficacy? Nobody? You'll get back to us.
I mean, I can try to take this to answer. I'm not part of PHAC and I'm not part of the modeling exercise. I don't have any insider's knowledge of the model. I think that what we're trying to understand at this point in time is the actual efficacy of the vaccines and effectiveness of the vaccines we have against the variants.
So we don't know. So this morning, a bunch of modeling came out and the pronouncement from PHAC was more lockdowns. But what I'm hearing here in this meeting is that you guys don't know. And so you're asking businesses to close and more lockdowns to be employed, but you don't know how many people need to be vaccinated or what assumptions you've used. Would that be a correct characterization of how you came prepared to this meeting today?
Well, I'm not answering that question. I'm just telling you,
Anyone from PHAC?
So, Mr. Chair, in relation to what has been presented, these models are forecasting based on a number of different assumptions. As we
Which
learn
we don't
more,
have yet. You haven't provided that.
Ms. Rempel-Garner, would you please let the witnesses answer?
So, but in terms of what goes into the models, for example, would be an assumption of the reproductive number. So 50% increase in the reproduction number.
But the reproduction number could be stopped by things like rapid tests and vaccines, correct?
Well, the reproduction number is an inherent aspect of the virus.
Right, but I mean, if we had tools to prevent the spread or the reproductive number, like rapid tests and vaccines, that in theory would change that, correct?
Well, but that has a significant interplay with for instance, vaccine efficacy. Vaccine efficacy, as we have.
So we don't know about vaccine efficacy.
Thank you, Ms. Rempel-Garner.
Thank you.
We go now to Mr. Kellaway, please. 5 minutes. Mr. Kellaway.
My apologies. I had a slight.
Mes excuses, j'avais un petit problème technique, mais je suis là. Je veux remercier les témoins d'être avec nous aujourd'hui. Je les remercie pour leur témoignage. Je vais partager mon temps avec le député Van Bynen. J'ai des questions pour la santé publique. Est-ce qu'on a besoin d'un registre de l'immunisation pour surveiller la couverture auprès des Canadiens? Monsieur Calloway.
So I'm hearing the French translation on the English channel.
Okay.
Perhaps we could take a look at that.
Sure.
Are we? I think we'll carry on a little bit, and I've stopped your time. I shall resume it now.
Okay.
Please.
I will try again, Mr. Chair, if that's okay. And sorry for the technical difficulties there. My first question is for PIAC, anyone from PIAC. Will there be an immunization registry to monitor vaccine coverage among Canadians? What's being worked on? Can you elaborate on that question, please?
Thank you, Mr. Chair. Thank you for the question. There are already immunization registries that are used across the country in every jurisdiction, including one that is now being developed in Nunavut with support from the Public Health Agency of Canada. And those are electronic databases that capture information on a per individual basis on immunization. And they're used for clinical management of people that have been immunized, and they're also used for surveillance purposes. So what we do at the national level is we draw from the data in those registries, working with each province and territory to assemble those data into our estimates of vaccination coverage across the country, as well as using them to monitor for vaccination safety and follow-up. We do not have one national registry, but the collection of registries are administered according to a standard approach that provinces and territories agree to. And in that way, we can be confident in the data that we are gathering from those registries and using to inform our programs at the national level. What's important is we look for trends and unusual happenings in the population with regard to immunization. And then we take action on those with manufacturers, with our regulatory colleagues, and with provinces and territories as we move forward to ensure the integrity of the overall immunization system in our country.
I'm sorry, Mr. Keller, for interrupting you once again. I just want to note that Dr. Quashtan has to leave at 4 o'clock, and so I would thank her for her appearance today and for making time for us and waiting for all the delays. And thank you. You may certainly feel free to leave when you require to leave. Mr. Kellaway, with my renewed apologies, please go ahead.
Thank you, Mr. Chair. And I am sharing my time with MP Tony Van Buyden, so I will let, if it's okay with you, Mr. Van Buyden, to ask some questions as well. Thank you.
Thank you, Mr. Chair. First of all, I want to thank everyone who's participating in this dialogue. It's great for us to get the benefit of scientific insights on this complex issue so that we have the benefit of facts as opposed to opinions to help inform the Parliament. Now, we've heard a lot about rapid testing. I'd like to confirm how many rapid tests have been deployed. And I've also heard that rapid testing will stop or will prevent the spread of variants. So first, how many do we have? How many have been deployed? How many are being used? And how does rapid testing stop the spread of these variants? And that's to whoever has the information available.
Yes, thank you, Mr. Chair. With respect to the precise number, there is a daily report that is provided, and we can provide the precise state of play with you by remit after the meeting today with the latest figures. With respect to the impact of rapid antigen testing on variants, it is not a direct connection between the two. So the use of testing in general through rapid antigen testing or alternative testing methodologies allows us to detect cases of SARS-CoV-2 in the Canadian population. And from there stems public health action to establish isolation and contact tracing of those individuals. If and when a particular individual is found to have a variant of concern, that can be further reported, but it cannot be done directly by the rapid antigen test. The rapid antigen test and all tests are there to detect cases and interrupt transmission chains.
And so that's a component of the projections that we had talked about earlier. My understanding is that there is over 22.6 million rapid tests that have been deployed as of yesterday, just for the benefit of the record. My next question, though, is that there's been a growing concern of the COVID-19 variants of concern in York Region, which where my riding is located. And my understanding is that we've invested $53 million to address these variants of concern in an integrated strategy. Can you tell me more about this strategy and how the Government of Canada is working with the provinces and territories to target these variants?
Yes, thank you, Mr. Chair. The investment of $53 million represents a multi-pronged approach to the response to variants of concern, including establishing a robust mechanism to detect rapidly and further characterize variants of concern. This represents a partnership of the National Microbiology Lab and PHAC, along with the Canadian Public Health Lab Network, Cancogen, the Canadian Genomic Network for COVID-19, and brings together all that information with CIHR to enable us to understand the spread, identify cases, and understand what the potential impact of these variants are.
Thank you.
Thank you, Mr. Van Bynen and Mr. Kellaway. We go now to Monsieur Thériault, allons-y, s'il vous plaît, 2 minutes et demie.
Bon, alors.
So, it's unfortunate that Dr. Quash had to leave, but I understand that she had her reasons. Dr. Poliquin, earlier you said that Pfizer, BioNTech, and Moderna, and with other vaccine candidates, you were doing a follow-up on their efficacy against variants. Is that correct? Answer: yes, that is correct. So, if with AstraZeneca, Janssen, and Novavax, you're doing that kind of trials, that kind of testing, why is it taking so much time to approve them and to put them out? If you're analyzing them, it's because they're relevant, right? Answer: what we're doing through the National Microbiology Lab and the integrated strategy is to characterize the variants. And with the lab, we want to better understand the potential impact of these variants. This needs to be added to clinical trials data so that we can better understand the potential impact. With regards to the approval process, that is a question for Health Canada. Okay, so I will then ask the question to Health Canada. And regarding vaccination, because of the threat of variants, and we don't know if we can detect them properly, there are probably more than what we can currently detect. Do you believe that the speed of vaccination is acceptable? Answer: with regards to our detection capacity, that's something that we are working on to increase our capacity in characterization and detection. Now, with regards to our ability to detect variants and the impacts of vaccine deployment, this is a complex question, and it's something that we are examining closely, the evolution of the variants and their impacts. Is it still relevant then to talk about a vaccine with 2 doses, or this is something that came up because of a lack of vaccines or not enough vaccines? Do you have any data on vaccinating 2 different strains? I would have to ask Dr. Quash to answer that. I don't know if Ms. Helmsley would have a question since Dr. Quash is gone.
Chair is showing a red sign.
The chair forgot to raise the sign earlier. I'm not used to 2.5-minute rounds. If you wish to answer Mr. Theriault quickly, I would appreciate it, and then we'll move on to Mr. Davies.
Right. As Dr. Quash said earlier, research is underway now to look at the impact of interchangeability of vaccines, at the durability of the effect of immunization, and those data are becoming available very quickly. As you know, and as she said, NACI will be, in fact, looking at more data from the UK next week. And so we are gathering, and the world is gathering and assessing information on dose schedule in a real-time basis so that we can be equipped to make those kinds of recommendations. And I should say, NACI has the breadth of expertise, which is why we rely on them as external experts to look at those data and give us their advice on dose interval, on the efficacy of one dose versus two, and on the durability issues that continue to be really important from a scientific perspective. Thank you.
Merci, et merci, Monsieur Theriault.
Thank you, Mr. Theriault.
Davies? Mr. Davies, please go ahead, 2.5 minutes.
Thank you. A recent lab study suggests that the South African variant may reduce protective antibodies elicited by the Pfizer vaccine by 2/3. Moderna just published a correspondence in the New England Journal of Medicine with data that showed a 6-fold drop in antibody levels versus the South African variant. Is there any anticipation that this reduction in protective antibodies will render the Pfizer and Moderna vaccines ineffective against the B.1.351 variant?
Mr. Chair, with respect to the protection afforded by these vaccines, it's important to put the effect of neutralization antibodies into the broader context. With respect to the degree of neutralization that's elicited, it is one of the proxy measures for efficacy. But we do not have a particular threshold that has been determined yet on a global level of what is considered to be truly protective. At this point, we note that the reduction in neutralization titers is notable, but it remains high. And therefore, we will need to continue to monitor the impact of this through ongoing clinical evaluations.
Thank you, Doctor. Now, AstraZeneca has said that it expects to have a new version of its COVID-19 vaccine ready for use by mid to late 2021 in order to respond to concerns about emerging variants that may be more transmissible or resistant to existing vaccines. Will Canada have access to this updated vaccine under the terms of our existing bilateral supply agreement with AstraZeneca? Does anybody know?
Mr. Chair, that would not be covered under the current agreements and would be covered by new negotiations.
Thank you, Doctor. Now, we know that about 130 countries have not received a single dose of vaccine to date. Do we have any concern that lack of vaccination will make the emergence of vaccine-resistant variants more likely?
Mr. Chair, the interplay of vaccines and the emergence of variants is a complex question that we are monitoring. We will note that the emergence of variants of concerns began before vaccine rollout programs occurred, with the first notable one being in August of 2020 with the D614G. Therefore, as we continue to move forward, we must be ready and continue to invest in our ability to rapidly detect and understand the variants of concern, which is why we are investing $53 million in the integrated vaccine a variant of concern strategy.
Okay, I'm not sure they have a. Sorry, Mr. Chair.
Thank you, Mr. Davies. You've got 3 minutes already, so.
Thank you.
So we'll start round 3 now. We'll start with Mr. Brassard. 5 minutes, please.
Thank you, Mr. Chair. I'm going to be splitting my time with Mr. McGuire. Quick questions here. For months now, Canadians have been hearing about 2 doses, and so I want an answer to this question. Was the 1 dose decision, did that come from PHAC or NACI, or was that political direction?
If I may, Mr. Chair, there has not been a 1 dose decision in the sense that NACI has provided its advice on the dose schedule for Pfizer and Moderna, and their current advice says that the dose interval should be no more than 42 days. As Dr. Quash said, NACI is now receiving evidence and research findings from Quebec, from the UK, and from other countries.
But we've actually heard, Ms. Imesley, that 1 dose could work. In fact, Dr. New said it could work as well. So where is this direction coming from? Is PHAC giving this direction?
So in the context of 1 dose could work, that's different from saying it would work. We do have preliminary evidence to say that there is high efficacy following 1 dose, but we need more data to understand the durability of that effectiveness and whether or not it wanes off. So that's why the discussion around the dose interval remains very, very alive in the scientific community. And that's why NACI will be looking at that again next week at their meeting.
Okay, so how does 1 dose affect the variant then in the data that you've received so far? Have you received any data at all?
I'm just trying to think about have we received data on the effect of the variant on 1 dose? I'd have to check on that and get back to you on that. I don't want to misspeak.
You're not misspeaking. This is evidence that's been provided publicly. There's been lots of discussions about 1 dose being effective in this case. So either PHAC is pushing this narrative, or it's coming from somebody else. So I'm surprised actually that you don't know where it's coming from. So I'm going to pass this over to Mr. McGuire right now. Thank you.
Yeah, I just wondered, 82% of the deaths have been coming out of long-term care homes, and we need to know more, I guess, about the 1 dose. Will people in long-term care homes be getting a booster in this area this fall before the first dose of vaccines have even been delivered to the general public?
So
Someone
what
answer that?
I would say there is these remain open questions. And as public health professionals, what we're doing is looking carefully at the science and trying to understand what the impact of variants will be. We need more data from countries that are doing research in this area. Those data are starting to come to us, and we're analyzing those carefully. And that's the way, of course, that we consistently provide our advice based on those data. And at this point, we're waiting for more data on now the
So is that data, is that data on seniors alone, or is it on all age groups? I believe that the briefing was talking about all age groups, and with how soon would Johnson & Johnson and AstraZeneca be okayed here in Canada?
So the latter question is a regulatory question that belongs to our colleagues at Health Canada. The former question in terms of age groups, it depends on the population being studied, but we do have data from older age groups.
You don't have any from younger groups, middle-aged people?
It crosses the spectrum of ages, and that's what we'll see, and that NACI will see next week as they receive further follow-up data on these populations.
Pardon me, because of time. Can someone answer the other part of the question then? Johnson & Johnson and Moderna, and AstraZeneca?
Was that a question on timing? Sorry.
Well, I was wondering that yes, it came up that they weren't going to be even authorized in the United States until mid-March. Is that true? And if that's the case, where are we at in Canada with them? That's only 3 weeks away.
Yes, and so that is a question for the regulatory authority at Health Canada.
Is there anyone here that can tackle that?
Thank you, Mr. Reguire. If anyone wishes to answer, please do so. Seeing none, I think we'll move on. We go now to Dr. Pawlowski. Dr. Pawlowski, please go ahead. 5 minutes.
Turn my face off rather than my mic on. I had a question about mixing and matching vaccines. I think the head of NACI brought this up, but I think certainly there is an interest in perhaps combining vaccines that might improve their coverage. I think she said that in animal models they tried AstraZeneca followed by one of the messenger RNAs, and it improved its efficiency. I think she did mention that studies are being done in England. Would you know, are such studies being contemplated in Canada, and would such studies get any financial support from the government? Certainly, I doubt it's in the vaccine company's interest to try mixing and matching, but it's certainly in the public interest if we can combine them. Thanks.
I don't know if Dr. Polican would like to comment on that, but as you said, that these studies are going on in the UK, and they are looking at combinations of Pfizer and AstraZeneca as a 2-dose sort of interchangeable approach to vaccination. So from that perspective, we are awaiting the results of the UK study. Thank you.
Yes, and Mr. Chair, just to build on that, the vaccine science is certainly an area of ongoing focus and interest, both in terms of evaluations within animal models, but more tellingly, some of these studies will need to occur in human clinical trials. And as we continue to learn more about vaccines, variants, and the interplay that they represent, additional studies will be contemplated.
Now, I think if you look at the existing phase 3 trials, those were at the expense of the vaccine producers. As I said, it doesn't seem like mixing and matching is necessarily in the financial interests of the vaccine companies. Who will provide the financing for those clinical trials to see whether this adds efficacy to the vaccines?
There's a range of funding mechanisms, Mr. Chair, to tackle these types of studies, including preclinical studies that can be done within laboratories, as well as human clinical trials that can be funded through a number of different mechanisms, including the Canadian Institutes of Health Research. And specific funding questions would be dependent on the study design.
Now, I'm not sure how much PHAC will take this issue on, but certainly I think there have been some recent studies that have suggested benlifinimab is effective when used early. As I recall the numbers from the New England Journal of Medicine study, it decreased visits to the emergency room and hospitalizations. I believe if given early, from 4.5% to 1.5%, in a higher risk people, 14% to 4.5%. Yet talking to clinicians, they're certainly having trouble accessing these forms of medications. It would certainly seem like potentially a second front on the fight of COVID if people who were high risk, once they got the disease, and there's actually been studies showing that in people in chronic care homes, I think you're probably familiar with, when it's given prophylactically to people who are so far negative for COVID that it reduces their risks of getting the disease. So it would seem like this would have some usefulness in institutions or places where there's high risk of contracting the disease and the people themselves are high risk if they get sick. and or treating people who are high risk as soon as they get sick. Has there been any efforts by Public Health Agency of Canada to try to assist the provinces who obviously have primary responsibility to get them these forms of treatment earlier, or do you still think this is too speculative?
Mr. Chair, I can start and I will give it to Mr. Swissmick to finalize it. But the government of Canada has been able to procure about 17,000 doses of bamlanivimab and has been distributed across the jurisdictions for their use according to their clinical guidance. So there has been also additional efforts to be able to bring together Eli Lilly and the provinces and territories to be able to get more evidence to be able to see where and how it could be used. So that's where we have done at this point. So I don't know if there's anything else to add.
Thank you, Dr. Pulaski. We go back now to the Conservatives. I don't know who's speaking at this
Me
point.
again, Chair.
Very well. Ms. Rumpel-Garner, please go ahead.
Thank you. When Dr. New was talking about potential one-dose directive, he said everyone can look at the evidence, obviously based on the local and provincial context, and make their own respective decisions. When the modeling was released today on the potential spread of the variant, did it factor into provinces choosing to use one dose of either the Pfizer or the Moderna vaccines and efficacy rates against the variants?
So just to be clear, the modeling that was released today was looking at epidemic curves and the potential interplay of the addition of variants to that. They were not specifically looking at the impact of different vaccine rollout.
Okay, so vaccine rollouts weren't considered in the modeling released today.
So it's different versions of different approaches to the vaccine rollout was not considered in the models today. It's specifically looking at one dose versus two doses.
So would PHAC be issuing to the provinces when they're saying, well, provinces would be able to make their own decisions? Is PHAC going to be providing data or a recommendation to the provinces with regard to one dose versus two in the context of the efficacy against the variant?
That is always part of the work that we do with provinces and territories. So what we will do is we will bring the analysis that we receive through NACI. We will bring the analysis that we do ourselves.
Has that analysis been completed yet?
That analysis will be completed as we get more data and as NACI receives more data next week from Public Health England and from other sources. So it's premature.
So the saying provinces would be able to make this decision was premature.
No, I'm saying it's premature to bring forward the data because we are awaiting it from another jurisdiction.
So there's no data yet, is what you're saying?
There are data from some trials. We're waiting for NACI to consider it and synthesize it as they do for us as part of their mandate.
So just going back on a different line of questions, which part of PHAC provided the advice to the government to undertake the quarantine hotel measure as opposed to expanding the Calgary border pilot program across the country as a better way to control the variant?
Mr. Chair, maybe I could just speak in general to the implementation of our border measures. In terms of trying to bring the pandemic under control, we're wanting to have public health measures which both address preventing community spread as well as the importation of cases. And
I'm looking
Canada
specifically to comparative models. So what data shows that the model that's being used at the Calgary Airport is less effective than the quarantine hotel method? Anybody? Is there any data on that at all? Was that a political decision or a decision made from PHAC? Did PHAC advise the government or did the government advise PHAC on the quarantine hotels? Did PHAC tell the government that we should be doing quarantine hotels? And if so, what was the data used?
Mr. Chair, I think that I may have indicated earlier that what we'd like to do is bring that data back to the committee, and we would undertake to do that.
I'm just asking because we've got the DG levels of most of PHAC here. Did PHAC advise the government to undertake the quarantine hotel measures, or did the government tell PHAC to make it so?
Mr. Chair, when we're looking at the prevention of the importation of COVID-19 cases, that would include the concerns that we would have with respect to the influence of the variants and the increases in the variants.
So quarantine hotels are more effective than the Calgary border pilot.
Ms. Rempel-Garner, I would remind you that appropriate courtesy and fairness should be displayed when questioning witnesses. I
also know when word salad is being given to me.
Ms. Rempel-Garner, I have the floor. I would request that you show respect to the witnesses and courtesy and let them answer your question. Thank you.
I'm also trying to show respect to the Canadian public, and I'm asking if PHAC advised the government on the quarantine hotel measures based on data that it was more effective than the Calgary border pilot measure, or if the government advised them to come up with rationale for this directive.
Thank you, Mr. Chair, for the question. What we can, again, reiterate is there's a need for a multi-layered approach with our public health measures. There's not one single measure which is going to work on its own. So the combination of effective quarantine for having the implementation of testing, we've introduced pre-arrival testing as well as a requirement for testing on arrival, and it's the combination of measures which is going to help us bring the pandemic under control. Thank you, Mr. Chair.
Thank you, Ms. Rempel-Garner. We go now to, where's my list? We go now to Ms. Sidhu. Ms. Sidhu, please go ahead.
Thank you, Mr. Chair, and thank you all the witnesses for being here today. My first question is Dr. Taro or Dr. Bent or Dr. Evan, if you want to give the answer. The National Advisory Committee on Immunization has released the updated new guidance for Canadian on COVID-19 vaccine efforts. Can you give a better sense of the work that goes into developing the releasing this guidance?
I'd be happy to do that. Thank you, Mr. Chair, and thank you for the question. As Dr. Quash, as Dr. Quash indicated, the National Advisory Committee on Immunization is a long-standing committee that has been providing advice to the Government of Canada, to the Public Health Agency on the optimal use of vaccines in the population over many years. They do their work by looking at the science and evidence that is available, and they are experts in their fields: immunology, pediatrics, infectious disease, behavioral science, economics. They consult with the Public Health Consultative Ethics Group, and their job is to, with all of that combined data and expertise, look at benefit to the Canadian public of particular approaches to vaccination. And so we rely on that expertise. We rely on the independence of the committee to bring forward the guidance that provinces and territories take into account as they make their own decisions on how they will implement their vaccination programs. The committee publishes statements, as you will have seen, on the COVID situation, and they update those statements as more evidence comes to bear. They use systematic methods for the analysis of their data, so it's always done according to international standards. They are one among a number of international committees called NITAGs, National Immunization Technical Advisory Groups, that work together and work independently as well to provide both global as well as domestic advice on optimal use of vaccines. Their advice has stood the test of time in this country. We see the success of vaccination programs. We see the success of efforts to prevent vaccine preventable diseases. And we also see from NACI where more research is needed and where there are gaps in our efforts to ensure that our population is well protected from vaccine preventable diseases. Thank you.
Thank you, Dr. Elmsley. I noticed that racialized seniors have now been included on the guidance list as a priority for vaccination. Many seniors expressed concerns about being at risk. Would you be able to comment on what kind of the data is being used to take this decision?
Yes, thank you again for the question. NACI uses epidemiologic data, and they look very carefully at the impact on population groups with respect to both the transmission of viruses, in this case SARS-CoV-2, and the impact on illness, particularly severe illness, hospitalization, and death. And so when they do their analysis of population subgroups, they see that certain groups, including racialized communities and seniors, are disproportionately affected by COVID-19. More illness, more severe illness, more death. And that feeds very strongly into the priorities that they set. They are very concerned, as we are at the Public Health Agency, about equity in the rollout of vaccines across the country. And so they put a special emphasis on using a equity framework to run their recommendations through to ensure that they are not leaving communities or particular groups behind, especially those that are vulnerable. Because as we all know, when we are ensuring that vulnerable populations are protected from infectious diseases like COVID-19, we are protecting everyone. We are protecting communities. Thank you.
Thank you. My next questions to Dr. Shimsky or Dr. Polkin, they can answer. On February 9th, Health Canada approved extracting 6 doses from Pfizer COVID-19 vaccine vials versus the previously approved. Can you give us an understanding of how it will affect the spread at which we will get vaccine, 6 doses instead of 5? Do you think it will impact on the speed at which we will get the vaccines?
Yeah, the witnesses, please go ahead and answer, and then Ms. Sidhu, you'll be finished.
It doesn't have a material impact on the speed of delivery, but it does allow more efficient use of the available vaccine supply globally.
Thank you, Ms. Sidhu. We will go now to Monsieur Thériault. Monsieur Thériault, allez-y. 2 minutes.
Monsieur Thériault, 2 minutes and a half.
Quoi ça améliore l'efficacité?
How does it improve the efficacy?
Remsky.
Dr. Remsky, you just said that it improves the efficacy. How does it improve it?
I was referring to that it improves the global supply ultimately.
Il n'y a pas de traduction, Monsieur le Président. Il n'y a pas de traduction.
There's no translation. I'm losing time here. Sorry.
Est-ce que nous avons l'interprétation?
Non.
Monsieur Thériault, if you have production, or sorry, translation, would you please give us thumbs up? No translation?
Ça fonctionne maintenant.
Ça fonctionne.
It works. It works now.
Alors,
Okay.
Dr. Remsky.
I've paused your time, and we will commence.
Pardon, Monsieur le Président?
Sorry, Mr. Speaker. Can you repeat? I paused your time. So now, we are going to resume your time.
Donc, Dr. Zumsky, vous avez dit en réponse.
Dr. Sumsky, in responding to Ms. Sidhu, you said that it wouldn't have an impact on the speed of deployment, but rather on efficiency. You perhaps answered my question, but I wasn't hearing the interpretation. So how does it impact the efficiency to go from 5 to 6 doses?
Okay, thank you, Mr. Chair. By efficiency, I was not referring to the performance of the vaccine. That has no change whatsoever with moving from 5 to 6. But what does change is that the amount of vaccine that can be provided from a given lot, a different production lot, becomes increased. So ultimately, the amount of supply available to all becomes enhanced. The amount of supply that's available to Canada remains what we have contracted.
You said that it doesn't increase the speed of vaccination if there are more doses. If there are more doses, I think that the rapidity would be quicker. But how is it more efficient when people who have to administer the vaccine say that they cannot extract these doses? 80% of the time, by Rick Illier, in early February, when the decision was made, 80% of the time, they're not always able to extract a 6th dose. In Quebec, it was 1 in 5 times. So beyond more vaccines, better it is. But if we are having such a difficulty extracting these doses, how is it more effective? How is it more quick? Why did we change the parameters of the contract? I understand that contracts is a matter of supply, but for public health, for the Public Health Agency, the efficiency of the vaccine, there are problems on the field that are persisting. Are you examining these problems?
Vous déposerez vos...
You can send a written answer if there's not enough time.
If I may quickly, Mr. Chair, the supply of the specific syringes that improve your chances of succeeding at the 6 doses are being distributed with the doses as they go out currently. And also there has been an extensive training made available to the health professionals across the country that will be instrumental in helping them achieve that goal. Thank you.
Merci, Monsieur Thériault. We will go now to Mr. Davies. Mr. Davies, 2.5 minutes, please.
Thank you, Mr. Chair. Are there any discussions currently going on at the Public Health Agency of Canada considering imposing restrictions on travel within Canada in order to prevent the transmission of variants of concern between regions?
Thank you for the question, Mr. Chair. The jurisdiction for the federal government and for the Public Health Agency of Canada with respect to the Quarantine Act is only as it applies to our federal borders. And so from that perspective, any restrictions on travel between provinces, interprovincial travel, would be at the purview of the provinces and territories. Thank you.
Thanks. Now, has the Public Health Agency of Canada revised its public guidance on infection control and prevention in response to the emergence of variants of concern?
Mr. Chair, thank you for the question. In the context of our overall guidance for public health measures, we continue to work with the provinces and territories to review our guidance in the context of variants, including instances where we should revise them based on new evidence or research sets available. We are in the process now of continuing to review the issue of variants and to make changes to our guidance.
If I may be more pointed though, the question was, have you revised your public guidance in response? I take it the answer to that would be, you have not yet, but you may be in the process of doing so. Would that be accurate?
Yes, I would say that in some instances we have made modifications over the course of the past several months, but we are in the process now with the provinces and territories of reviewing our guidance.
Okay. Now, just to get to a really basic question, does the severity of disease caused by emerging variants of concern differ from the disease caused by previously dominant strains of SARS-CoV-2 virus?
Mr. Chair, the issue of severity is one of the markers that would elevate a variant to a variant of concern. The determination of increase in severity is work that has been underway for the 3 variants of concerns most reported to date. Preliminary results from the UK suggest that there may be an increase of severity amongst older individuals affected by the variant first identified in the UK, not children. But these are fairly complex epidemiological studies that have to take multiple factors into account, including strain on health systems. And so the precision of that estimates will be lagging as the science evolves.
Okay, if I can squeeze a final question. What impact, if any, has the emergence of new variants of concern had on Canada's vaccination strategy?
Witnesses may answer, please, quickly.
So if I may, I would say, Mr. Chair, that the emergence of variants of concern have certainly added an important dimension to all of the work that we're doing under a vaccination strategy. As we look at the effect on transmission, and as we look at the effect on severity of disease. It does not change the plans, of course, that we have for rollout of vaccine. That continues to happen, and that needs to happen as it has been set out. But as we look at the effectiveness of vaccine, for certain, variants of concern matter as we assess vaccine effectiveness.
Thank you, Mr. Davies. So committee, we are at, we've just completed round 3. We are almost at the 2-hour mark. I wonder if it is the wish of the committee to continue to a 4th round. I'm not sure how to evaluate that. Does I'll ask people to raise their hands if they want a 4th round. Okay, I see a number of hands going up. So thank you to the witnesses. We will continue for at least one more round. And so we will start the 4th round again with the Conservatives. I don't have who's on the list for the Conservatives. Ms. Rebel-Garner, would you advise, please?
Sure, I guess I'll just go for it, Chair. I guess today I'm fairly concerned about the data that is being used to inform decisions that are costing trillions of dollars to the Canadian economy, lives and mental health. I find it extremely shocking that, and I understand that people are trying to do their best, but I find it shocking that people came to this, at these levels within the bureaucracy, came to this meeting without being able to provide basic information on modeling that was released as early as this morning. So I'm just wondering if perhaps somebody in PHAC from one of these departments can explain to me how some decisions are being made. So let's start with travel measures. How did the quarantine hotel, I'm just wondering how did this decision come to be? Like how did this come into place? Was it PHAC advising the minister, or where did that discussion start?
Mr. Chair, thank you for the question. When we look to the border measures, important conversations that we have occur at our special advisory committee, where we have discussions with our Chief Public Health Officer, as well as with the Chief Medical Officers of Health for all of the provinces. An important aspect of that conversation has been the concerns with respect to importation of cases in Canada. Similarly, we look to other, Mr. Chair, if I may finish my answer. Similarly, we look to other jurisdictions who are experienced issues with the variants to see what measures they may have employed with success. And UK certainly figured in the look that we had to other models. Thank you, Mr. Chair.
So what data was used to inform that decision? Specifically, did the UK provide evidence that measures that they had put in place stop the spread of variants?
Thank you for the question, Mr. Chair. I'll start off, and then I may turn to a colleague with respect to what we're seeing in terms of the rates of positivity of imported cases. So certainly we would look at for the travelers coming in and the rates of of positivity that we're seeing from those travelers, including where we may have associations with variants of concerns, and that will impact on the public health measures that we put in place, and also what we learn and know about the timeline of
just because I have limited time,
spread.
This isn't quite where I wanted to go. I'm just wondering what data showed that quarantining in a quarantine hotel would have a better public health outcome than quarantining at somebody's house.
Thank you for the question, Mr. Chair. As I've mentioned, one of the things that's important is taking a multi-layered approach in our public health measures and having effective quarantine measures, particularly at the front end where the infectious period is developing, is an important aspect of that.
What data was used to inform that comment or that talking point? And specifically that quarantining at a hotel was better than quarantining at somebody's house?
Thank you for the question, Mr. Chair. As I've said, one of the key pieces of evidence for the Public Health Agency was with respect to the development or our understanding of the rates of the variants that were happening, how we are aware of the rates of positivity of travelers that are coming into Canada. Mm-hmm. Our conversations with our chief medical officers of health with respect to adherence to quarantine measures and how we could put more robust measures in place to assist in reducing community spread as a result from linkage to travel.
Could you table with committee next week the data that you used that showed that quarantining at hotels would be more effective than quarantining at somebody's house? Would you do that next week? Does that data exist?
Ms. Rimple, I don't believe that was the witness's testimony.
I'm just asking, no, Chair. So to the witness, through you, Chair, could they please table with committee the data that they used that showed that quarantining at a hotel was more effective than quarantining at somebody's house?
So once again, I don't think the witness asserted that.
But I'm asking that question. Can anybody at PHAC table data that shows that quarantining at a hotel is better from a public health perspective than quarantining at somebody's house?
So, Mr. Chair, thank you for the question. What we can bring forward is certainly happy to take that question back to the department and look for.
Can you table that with committee through you, Chair?
Just for clarity, Mr. Chair, and just to bring forward the rationale in support of this.
Could you table with committee the data on adherence to quarantine for the last year? Does that data exist?
Mr. Chair, we'd be happy to take that question back to the department and bring forward information with respect to adherence to quarantine measures that's available. Thank you.
Was that data used in informing the decision to make people quarantine at a quarantine hotel, which I note in the main estimates is going to cost $250 million? So what data was used to inform that decision? $250 million. What data was used? Anyone? I mean, it's just $250 million. I mean, what's that between friends, right? Anyone? Any data? No?
Thank you, Ms. Rimple-Garner.
Thank you, Chair.
We go now to Mr. Van Bynen. Mr. Van Bynen, please go ahead, 5 minutes.
Thank you, Mr. Chair. On October 23rd, 2020, the federal government announced funding to a biopharmaceutical company, Medicago, based in the city of Quebec, for vaccine manufacturing facility in that city. The federal government has also recently announced the signing of a memorandum of understanding with Novavax to pursue options to produce its COVID-19 vaccine at the National Research Council of Canada's Biologics Manufacturing Centre, once both the vaccine candidate and the facility has received the required Health Canada approvals. It was reported on the 14th of February 2021 that the federal government would meet soon with provincial governments to discuss collaboration on building up domestic biomanufacturing capacity. So, to whoever is appropriate, In your opinion, how much will these initiatives contribute to Canada's vaccine supply, and how long will it take to establish?
Any witness who wishes?
If I could take that, Mr. Chair, the initiatives that are being described are led out of the industry portfolio, and that they would be best positioned to answer those type of questions.
Okay. To your knowledge, would there be any private sector options to produce the COVID-19 vaccines domestically that the federal government could have pursued earlier? And if so, what were those options?
The Medicago is a private company.
What is it? Okay, right. Thank you. Can you describe Canada's past and present pharmaceutical and bio production landscape, and what we should be doing to make ourselves more self-sustainable as we go forward?
Mr. Chair, again, if I could indicate that the biomanufacturing strategy that Canada is pursuing is led by the industry portfolio.
Let's go then to the vaccine effectiveness. Please explain the concept of herd immunity and what portion of Canadians are needed to establish a herd immunity. And I know that's a complex question, but we hear the term so often. Could you please explain what the intent and the impact of that would be? Gosh,
Thank you.
Go ahead.
Thank you so much, Mr. Chair. Yes, so herd immunity, of course, as you mentioned, is a concept that we hear about a lot. Some areas of science will put percentages around it, saying we need to reach a certain level of immunization in the population to achieve herd immunity. Others will talk about it in terms of time frame. From a public health perspective, I would say that we in the field are cautious when it comes to pronouncing on a particular percentage of the population required to achieve herd immunity, which is essentially a place where the virus can no longer efficiently transmit. And therefore, because people are protected, either they have been protected through vaccine-induced immunity or through natural infection, and they are now immune. And so when the virus has nowhere to go, it can't continue to transmit, and you have achieved herd immunity. And that protects people who are unable to be vaccinated because, for example, they may have contraindications to a vaccine and therefore not be able to receive it. There may be allergies that prevent them from receiving it. But when you reach that place where the virus has no efficient way to transmit between people, then essentially you've reached herd immunity. You see drops in the level of disease in the population, and of course in transmission in the population. So at the Public Health Agency, what we're doing is monitoring all those indicators. We're looking at vaccine effectiveness. We're looking at within subgroups of the population, what kind of transmission rates are being seen, and we continue to look at those. We look at the reproduction factor, all of those, as you said, it's sort of complex. But at the same time, the concept is a pretty simple one. And so we will be looking at those indicators as vaccine rollout continues, as public health measures continue to be implemented in order to see spread of virus decrease. Thank you.
Thank you. How much time do I have, Mr. Chair?
Effectively none. Thank you, Mr. Van Bylen.
Thank you.
We go now back to the Conservatives. Ms. Rempel-Garner, is it you again?
Mr. Barlow.
Mr. Barlow, please go ahead, 5 minutes.
Thank you very much, Mr. Chair. And maybe somebody from PHAC, what is the percentage number of Canadians who have to be vaccinated before we have no longer have lockdowns and travel restrictions and quarantine restrictions are lifted?
Mr. Chair, that is, I'll begin, and Ms. Hemsley may have additional comment. On the issue of the necessary level of protection, that is a dynamic question. As we continue to learn more about the effect of variants of concern on long-term efficacy of the vaccine, we also need to understand the duration of immunity in the population, as well as the effect on transmission. So it is a complex number that is potentially going to change over time as the state of the science evolves.
You know, I hope the representatives from PHAC here today understand how devastating these lockdowns are to Canadians, not only for businesses, but for Canadians' financial and mental health, which is being profoundly impacted. And the concerns that we're hearing is, just from today, is no data is being provided to warrant these lockdowns. So why isn't this information available that can warrant that I can go and tell my constituents that the reason that you're being asked to lock down further is because of A, B, and C? Why isn't that information available?
Mr. Chair, on the issue of the changes in the outbreak dynamics and the impact of public health measures, as has been mentioned previously, there was modeling released today, which shows a number of different scenarios, including the maintenance of current public health measures. And the
Mr. Maybe I can put it this way. Sorry, I hate to interrupt, but maybe I can put it this way. When will you know? When will you have this? When can you put a timeline, and when you'll have the data sufficient to understand how many Canadians would need to be vaccinated before we have what would be acceptable herd immunity and no longer reasons for lockdown? When would you have that data available?
So that is, Mr. Chair, that is a question that is a moving question or a moving point as we learn more about the interplay of this virus. We continue to learn more on a daily basis about transmission dynamics. And now we have the additional layer of complexity introduced by variants of concern, which have different properties and different impacts on transmission. So these are live questions that continue to be updated and explored as we learn more.
Okay, thank you. So what I'm hearing is you have the data available, which I actually haven't heard that today, but PHAC and the government of Canada, the Liberal government, apparently has the data to enforce border lockdowns and travel restrictions and quarantine people in hotels. You have that data, but you don't have the data available that we can tell Canadians when life can go back to normal, Canadian businesses can reopen, and Canadians can go back to work. We don't have that data. Is that what you're saying?
So, Mr. Chair, on this issue, data is not a fixed concept. We continue to learn more and to learn about this and add to our understanding of the transmission dynamics. The modeling that was released today demonstrates a number of different scenarios, including one where variants of concern with a 50% transmissibility increase are in play in Canada. And we see from that data that public health measures are a necessary component of achieving outbreak control here in Canada.
And I appreciate that, but this is having a very real impact on Canadians, and they need some answers. So the last question I want to try and get out to Mr. Chair, if I have some time here, is we've heard today some very different perspectives that I think we've heard is if we have the most robust access to vaccines in the world, which we keep hearing, even though we don't actually have vaccines in hand, we keep hearing that we have access to them, then why are we now rationing those vaccines? And we've heard today that we may be extending the time between the first and second dose, or maybe even we won't even need that second dose at all. Why such a change in the information that we've heard from the beginning of or the last few weeks to what we're hearing today? Why that massive change in, if we have all these vaccines, why we are rationing and then maybe having, instead of 2 doses, only 1?
This is a matter of the evolution of the science. It's really as simple as that. We're learning more about the effectiveness of vaccines. We're learning more about the efficacy of 1 dose or 2 doses. This is all quite expected in the context of watching the population in its response to vaccines and watching vaccines as they interact with our population. And so, to be quite clear, it is us as a globe, learning about, through the science, how to use vaccines most effectively. And that's what this conversation is about. And so when Moderna and Pfizer were authorized for use in Canada, they were authorized according to the clinical trial data that the companies brought to the regulator. Once the vaccine is in use in a population, as with all vaccines, then you look at effectiveness in the real world and you start to understand whether or not the way that the vaccine is being delivered in a population can be revised, and whether or not those adaptations that you might make are having significant public health benefit. If they are, then you can modify your use. If you see that things are moving in the wrong direction, again, you modify your use. But it is squarely the evolution of science.
Thank you, Mr. Barlow. We go now to Mr. Fisher. Mr. Fisher, go ahead, 5 minutes, please.
Thank you very much, Mr. Chair. And Ms. Elmsley, I just want to thank you for hitting the nail on the head there. It's the evolution of science, and that explains so much. You know, this is, from day one, this has been a rapidly evolving situation, and I know that all of you, all of the people that are taking care of Canadians and watching over the health and safety of Canadians are constantly monitoring new data every day as it arrives. Now, we all know, I think we all agree in this committee that we have to do everything we can to protect Canadians from COVID, especially with these new variants. One new case of COVID is too many. And I want to thank you all the witnesses today for the work that you do every day, because I suspect that you live this. You live this, and you have for probably a year. Now, you didn't get a chance to answer all the questions that were asked of you. Members are very tight with time. We have a lot of constraints on the time here, and you didn't get a chance to answer all the questions that you were asked. But you specifically mentioned the importance of a multi-layered approach to controlling and preventing COVID-19. And I wonder, and I since I'm on with you, Ms. Elmsley, wondered if maybe you could elaborate on this multi-layered approach on how we need to do everything, take every step to make sure we ensure the safety of Canadians.
Yes, thank you for the question, Mr. Chair. This is something that I feel passionate about, and I think we all, as public health professionals, feel passionate about this. That when you're dealing with an epidemic or a pandemic, when you're dealing with a public health crisis, you need to use all the levers you have in order to interrupt transmission and to save lives. And so from that perspective, when we talk about a multi-layered approach, we talk about vaccine as part of our toolkit. We talk about public health measures, and we've learned over time how effective those public health measures are, whether they be for the wild strain of the vaccine or for variants. We know very clearly that masking, physical distancing, washing hands, all of those public health measures work. And that's why they become so important to our multi-layered response. We also, of course, rely on Canadians and know that Canadians are sacrificing and doing so much to ensure that we are controlling the spread of this virus in all of its forms. And so public health is a team sport. We know that, and we need to work in collaboration with the whole of society as we tackle this very complicated problem. We don't have all the answers, and we don't pretend to. Nobody does. But what we're doing every day is getting more data, doing analysis, trying things out. Sometimes you take a risk and you try something out, and then you collect data as you go to see whether or not your best informed public health interventions are working or whether they're not working. And we're in that space right now. We've been in it since the beginning of this pandemic. We'll continue to be in it as we now roll out vaccines at the same time as we reinforce public health measures and work with Canadians and communities to ensure that they maintain confidence in the vaccines that are being provided and that they will access over the next short while as the number of vaccines delivered to our country increases. So I'll stop there. I probably have maybe been a little bit too impassioned, but I feel very strongly that we use our levers, we adjust our levers, we use evidence, and we apply evidence very effectively in Canada in order to deal with this devastating pandemic.
Well, I for one, thank you very much, and thank all the folks that do the work that you, very similar to the work you do. But I also want to take a chance, if I could, Mr. Chair, I know my time is just about out, but I want to thank the public health officials in the provinces and territories for working as a team, looking out for the health and safety of Canadians for a year now. It's absolutely incredible. Here in Nova Scotia, we've had some pretty significant success as we've fought COVID, but of course, we've had to take some pretty serious public health moves, and we've had buy-in from the community, and Canadians have bought in essentially to a lot of the suggestions from their amazing public health officials across this country. So I want to salute them all with my last 10 seconds. Thank you so much, Mr. Chair. Mr. Chair, you're muted.
Sorry. It was so wise too. So anyway, thank you, Mr. Fisher, and we will go. Nous allons maintenant, Monsieur.
And now let's move on to Mr. Thériault. Mr. Thériault, you have the floor, 2.5 minutes. Thank you. It's always better when I can hear you. I would like to reiterate to the witnesses that their responses today are important, as well as any additional information that they can share with us in the coming days. I don't think that anyone here today, on February 19th, 2020, could have foreseen the events of this crisis. And nobody could have claimed last February that we would have been asking so many questions on the efficiency of a vaccine, because it's not even something that was a possibility at that time. So there are positive things and negative things, but among these negative things, Dr. Tam came to one of our meetings, and you have to be humble when you look at a crisis such as this one. And I asked her, would she have closed the borders sooner? And she said yes. With border management and pandemic management and with consultation, yes. This week, the land border was open. Quebec was quite concerned with the break week coming up because it could be a significant problem in Quebec. Were you able to focus on the border, the land border this week? For example, Lacolle specifically. Madam Evans.
Thank you, Mr. Chair, for the question. So we have, there are now requirements for pre-departure testing for arrivals in Canada through our land borders, and that came into force on the 15th of February, specifically to the point that that the member has raised. And so,
il paraît que c'est très...
So apparently there's fraud there. Thank you, Mr. Thériault. I think you're not aware of the problems that occurred this week. I will share them with you later. Thank you. Thank you, Mr. Thériault.
To Mr. Davies. Mr. Davies, 2.5 minutes, please.
Thank you. Several provinces have recently eased COVID-19 control measures or are contemplating that, despite the spread of variants of concern across Canada. Does PHAC have a position on that? Is that a wise course of action for provinces to be easing controls when we're seeing the emergence and spread of variants of concern?
Thank you, Mr. Chair. That is a a complex question. And so I will maybe speak to the modeling that was presented, and then Mr. Bent may have some additional commentary. We demonstrated or displayed today modeling that shows that with the introduction of variants is one factor that affects the epidemic curve. And we see that different levels of maintenance or relaxation of public health measures does also have a potential impact on outbreak trajectory to control. And with that, I would like to turn it to Mr. Bent in terms of the view forward.
Thank you. So perhaps to build on my colleague, Ms. Elmsley's comments from earlier, it's very much about a toolkit of measures. And at the provincial and territorial level, they take a regional approach based on the incidence of COVID and the challenges that are being faced in specific communities. In the context of going forward, I imagine that that will continue as an approach as we watch the surveillance related to rates of COVID-19, hospitalizations, and other important surveillance measures that help inform decision-making at the provincial and territorial and local public health level in terms of how to manage COVID-19.
Okay. Now we know that one of the attributes of these variants of concern is greater transmissibility. They're frankly more infectious viruses. And I'm just wondering about the relationship between transmissibility and PPE advice. Does PHAC have any comments to make on how the variants may impact our PPE? We know that we had a great deal of problems with PPE in this country early on in this. I'm just wondering, is there any guidance that Canadians need or should have about masking or any other precautions they can take in terms of PPE measures?
Mr. Chair, thank you for the question. Perhaps most beginning broadly, we know that the measures that we have in place work. The research and evidence that we will build and continue to draw on will help inform how we provide advice to Canadians on how to adapt the measures that we have in place. In terms of masking, we continue to review our advice to Canadians. We recently did so. And continue to monitor work that is happening in other countries and in the research community. In the context of masking, we continue to advise that a non-medical mask with multiple layers, including a filter layer, remains a very good and useful approach to reduce the spread of COVID-19. We continue to monitor, as I've mentioned, activities that are happening in other jurisdictions, but based on the evidence available to us today, our advice remains that in the context of variants of concern, that the current masking advice remains appropriate.
Thank you.
Thank you, Mr. Davies. So that brings us to the end of round 4, and it also brings us very much past our 2 hours that we had proposed for this meeting. I'm wondering if it is the will of the committee to adjourn at this time.
So moved, Mr. Chair.
It seems to be the will of the committee, so therefore, thank you all, and I thank you all. I thank all of the witnesses for being with us today, for abiding with us through all of the delays earlier on, and for your testimony today. So thank you all, and see you all next week. Meeting adjourned.
Thank you to the